Hello, future RNs. Today, we're exploring two electrolytes that often fly under the radar, but are absolutely crucial: phosphate and chloride. These tiny ions keep our cells energized, our acid-base balance stable, and even affect the heart and bones. By the end of this video, you'll understand not just the numbers on labs, but the story behind each electrolyte. Let's dive in. 1. Phosphate, PO4, triplet negative. Phosphate is like the energy currency of the body. Without phosphate, cells can't make ATP, meaning your muscles, heart, and brain would literally have no energy. And 85% of phosphate is stored in bones with calcium, so it's also key for skeletal health. Normal serum range: 2.5 to 4.5 milligrams deciliter. Functions: energy production, ATP, creatine phosphate, and cellular metabolism. Bone and teeth formation, works closely with calcium to maintain bone strength. Acid-base balance, phosphate acts as a buffer. RBC function, part of 2,3-DPG, affecting oxygen delivery. Cell signaling, phosphate groups regulate enzymes and hormones. Regulation. Parathyroid hormone, PTH, dephosphate by increasing renal excretion. Vitamin D, calcitriol, up phosphate absorption from gut. Kidneys, major route of phosphate excretion. Causes of imbalance: hypophosphatemia, less than 2.5 milligrams DLE. Malnutrition or starvation. Alcoholism. Refeeding syndrome, rapid nutrition after starvation. Hyperparathyroidism, increased renal excretion. Certain medications, antacids, diuretics. Hyperphosphatemia, greater than 4.5 milligrams per deciliter. Chronic kidney disease, decreased excretion. Hypoparathyroidism. Phosphate retention. Excess phosphate intake. Tumor lysis syndrome, rapid cell breakdown. Clinical signs and symptoms: hypophosphatemia, muscle weakness, fatigue. Respiratory muscle dysfunction, may require ventilatory support. CNS, confusion, irritability, seizures. Bone pain or osteomalacia in chronic cases. Hematologic, anemia, platelet dysfunction. Hyperphosphatemia, usually asymptomatic initially. Tetany, due to associated hypocalcemia. Soft tissue and vascular calcification if chronic. Itchy skin in CKD patients. Nursing interventions. Monitor serum phosphate in CKD, TPN, and post-refeeding patients. Administer phosphate orally or IV in hypophosphatemia. Educate patients on phosphate-rich foods, meat, dairy, nuts. In hyperphosphatemia, use phosphate binders, manage CKD, and monitor calcium levels. Watch for calcium phosphate balance. Hyperphosphatemia, often hypocalcemia. 2. Chloride, Cl-. Chloride might seem simple. It's just an anion. But don't be fooled. Chloride is the main extracellular anion, essential for maintaining fluid balance, osmolarity, and acid-base equilibrium. It often follows sodium and is tightly linked with bicarbonate. Normal serum range: 95 to 105 millicuries liter. Functions: maintains osmotic pressure and fluid balance. Acid-base balance via bicarbonate chloride exchange, chloride shift. helps maintain electrolyte neutrality in plasma, supports gastric acid formation as HCl. Causes of imbalance. Hypochloremia, less than 95 milliequivalent per liter. Loss via vomiting, nasogastric suctioning. Diuretics, loop or thiazide. Addison's disease. Excess bicarbonate therapy, relative chloride deficit. Hyperchloremia, 105 milliequivalent liter. Dehydration, water loss concentrates chloride. Excess saline infusion, NaCl, kidney dysfunction, impaired chloride excretion. Metabolic acidosis, non-anion gap. Clinical signs and symptoms. Hypochloremia. Often asymptomatic initially. Signs related to underlying disorder, dehydration, muscle cramps, irritability. Metabolic alkalosis if caused by vomiting. Hyperchloremia. Often associated with metabolic acidosis. Weakness, lethargy, deep rapid breathing, compensatory. Can worsen kidney function in CKD or ICU patients. Nursing interventions. Monitor serum chloride in patients with vomiting, NG suction, or IV fluid therapy. Monitor acid-base status, ABG, in ICU patients. Educate patients about proper hydration and sodium chloride intake. Correct underlying causes, replace losses, adjust IV fluids, manage kidney function. Remember, chloride usually follows sodium, so always consider Na levels too. 3. Phosphate and chloride interplay, nursing insight. Quick tip, nurses, phosphate and chloride may not seem connected, but both play huge roles in acid-base balance and cellular function. Phosphate buffers pH in cells, while chloride balances extracellular fluids and shifts with bicarbonate. In CKD, you can see both hyperphosphatemia and hyperchloremia, so always check both and think about the bigger picture. Nursing mnemonic. Phosphate, powerhouse and protector, energy plus bones plus RBCs. Chloride, companion of sodium, fluid, osmotic balance, acid base. All right, future RNs, that's your deep dive into phosphate and chloride. These electrolytes may be silent, but their impact is massive. Remember, labs are numbers, but symptoms tell the real story. Like, share, and subscribe for more deep nursing lessons. Keep learning, keep caring.